Hello, everybody. I'm Steve Stahl, and I'm recording this in my office in San Diego. So I hope you enjoy it. We're going to talk today about anxiety, malaise in the modern world, or is it a secular disorder? And also maybe we can address what's new. So I'm here in San Diego. I'm a professor of psychiatry at the University of California, San Diego, and we're going to get going. This is my disclosures. You can read these if you wish. This has to do with consulting or board activity or grants that I've gotten. And now we begin. The objectives of this talk are, first of all, to provide you with an overview of the LIBS SNC project of medical education, which they call states of mind. And so this is part of it, my little talk today. We're going to review also then the importance of the principal anxiety disorders and then discuss the brain pathways involved in the symptoms of these anxiety disorders, okay? And after we talk about the disorders and their pathways of the brain, we're going to talk about the treatments. So present the treatment options and their rationale and mechanism of action. So what is the states of mind project of medical education? Here it is. A group has put together several eminent experts who will author 6 pocketbooks covering each of the principal anxiety disorders. And each of those authors, in parallel, will also lead a class or discussion of 30 to 40 minutes covering the points raised in the pocketbooks. Those classes will be recorded if you don't go to it live, and they'll be available on the website at www.statesofmind.com.er. So in summary, what's the program? 5 principal anxiety disorders, 6 pocketbooks, 6 classes or discussions, live and recorded for online, and an inaugural class, which is right here. This is one. So this is the first part, a kickoff, you would say. So what are the principal anxiety disorders? Well, it depends on which classification you use, or you could say, well, maybe it depends on who you ask, but pretty much everybody would agree that GAD, generalized anxiety disorder, is a principal anxiety disorder, and SAD, social anxiety disorder, also is one. Even panic disorder, PD. And then you get into some reclassifications, changes of opinion, and even controversy. What is PTSD? In the DSM-5, it was put in a new category about trauma-related disorders, and it certainly is that, but it does have some symptoms of anxiety, and it overlaps with them, and for our purposes today, we're going to include it. And the other one is what? OCD, obsessive-compulsive disorder. It was pulled out of the anxiety disorders by the DSM, but this is not necessarily an agreement point with the ICD. So it depends on which classification you use. But OCD does have some anxiety associated with it, and we will talk about these all 5 as though they're anxiety disorders, recognizing that some people think otherwise. So the first point I want to make is that MDD is major depressive disorder, and there's a great deal of overlap with the anxiety disorders. So if you look in the middle there, that's the central symptoms of a major depressive episode, either depressed mood or loss of interest. And surrounding it are several other symptoms. And you got to have 5 total symptoms or else you don't got major depressive disorder. And you can have some mixture of that, many. But what I'm going to show you now, when I click on it, is that the middle symptoms are going to change. The central core symptoms of GAD are different, and some, in other words, the ones there in color, are the same additional symptoms, and some are different. You ready? So here we go. Now that's GAD. Centrally now you have to have anxiety and worry. But look, those some things on the side, the sleep, concentration, etc., that colored group is the same. So you go back and forth. What's the difference between MDD and GAD? And the short answer is not a whole lot. And the other thing is that many people with MDD have GAD. And so there is some argument that actually they're very similar disorders. Some of the symptoms are different, but it's also probably not an accident that essentially any drug that works for MDD also works for generalized anxiety disorder, GAD. Okay, let's press on. So GAD then has generalized anxiety and worry and generalized fear. So your fear of a lot of things, nothing specific, everything in general, fear of the future, fear of the past, worry about money, this kinds of things. And several of the additional symptoms around are part of the diagnosis. And what you're going to see is a pattern emerging here. In the middle is always some form of anxiety and some form of fear. And around it are several other symptoms which are very similar across many of the disorders. This leads us to believe that they are all related to each other and even to major depressive disorders I showed. So here's GAD. Here is panic disorder. And what's in the middle of that? Panic attacks, right? But you actually have forms of worrying about getting that attack. You're afraid of it. And so forth. There's a type of worry and a type of fear, a little different in panic disorder. And you have to have, by definition, some unexpected panic attacks. Because if you only have expected panic attacks, you probably have social anxiety disorder, in which case the central fears are a little different and the central worries are a little different. They are more related to social situations. And guess what? You can have panic, yeah, but it's all expected. You're going to go into a situation often where you're being scrutinized by others and you say, oh my God, oh my God, oh my God, boom, you have a panic attack, but you know you're going to have that panic attack. If you have panic disorder, on the other hand, what happens here is those panic attacks come out of the clear blue sky, boom, for no good reason. But it happens that when you get that panic attack in panic disorder, whatever you're doing at the time, you think caused it. So if you're crossing a bridge in a car, well, it must bridge cause it. If you are, seeing something green, maybe you think green causes it. But the reality is these are unexpected. You can have some expected ones too in panic disorder, but by definition, the panic attacks in social anxiety disorder are expected. Now we get to PTSD, post-traumatic stress disorder. Is this an anxiety disorder or not? Well, I think it is, because you can show that there's a form of worry and anxiety that is a central core with some of the surrounding symptoms that are different. So clearly it's caused by different things and experiences than some of the other disorders, and clearly it's got additional manifestations which are quite different, and it is trauma related, so some people would categorize it. But we're going to show that some of the circuits, especially the central circuits, which are common to all these disorders, are the same. Finally, OCD. Some people think there's a special category called impulsive compulsive disorders, or impulsive disorders that have to do with other things. But for our purposes, we're going to say these are obsessions and compulsions that have specific types of worries and fears. And of course, they're followed by behaviors called compulsions. So let's take a look now at what the symptoms are. Sometimes I call this kind of section symptoms and circuits. What are the brain pathways for any psychiatric disorder? Today, we're going to talk about the symptoms of the principal anxiety disorders, and we're going to start with fear and worry and talk about a few others. So every psychiatric disorder has symptoms, and the theory is that there's a topographical organization of function, so that when you have one symptom, it's in a certain circuit that isn't working right. You could say it has inefficient information processing. But if you have a different symptom, it's in another circuit, and it has inefficient information processing. So, depending on which circuits are sick, depends on the symptoms you have. And eventually, that'll dictate which kind of drugs to use. But let's get started and say, what about these circuits? Well, before you even get to a specific diagnosable full anxiety disorder, you may be normal. But if you grow up around child abuse, it is not good. Obviously, that makes sense. But there's evidence in both human and, of course, in animal studies that much of the sensitization that occurs with child abuse centers on the amygdala, an interesting area of the brain. And if you have no stress, obviously, you get a get out of jail free card. What's interesting, though, is that if you have a little bit of stress, you actually develop a little bit of resilience, and it might actually be better because life is full of stress, and a little bit of stress might actually kind of harden your circuit a bit. But if you have overwhelming abuse, sexual abuse, trauma, physical abuse, neglect, the idea is that you sensitize the circuit, but guess what? It might be silent. It might be silent. It's just lying in wait for the next psychosocial stressor to hit you, perhaps in adulthood. So you've got a sensitized child, but not a sick child yet. But underneath the surface, there is a sick circuit. And now what happens is that you introduce multiple adult life stressors to the first two groups, and they don't get sick. Maybe they can eat stress for lunch. It's the idea is that they can process it. Life is full of stress. There's good stress. It makes you grow. But people that have too much stress and also a sensitized circuit, they're the ones that are really at big risk for basically turning into a generalized anxiety disorder of some sort and also a depressive episode of some sort. So it's not a good combination to have stress in adulthood plus child abuse before you get to adulthood. What happens? You could say that there's addition to the amygdala being sensitized that you can also change your hormones. And this is a classical HPA changes, hypothalamic, pituitary, adrenal axis. So normally you have that functioning and normally make some CRF, corticotrophin releasing factor, which tells the pituitary, hey, make some ACTH. And the ACTH comes out and goes to the adrenal and says, hey, make some glucocorticoids. Then the glucocorticoids come back when they're too high, and then they say to CRF, hey, better slow down. That's called negative feedback, so you don't make too much hormone. Well, what happens under stress? It turns out that the feedback loop gets messed up, and you have a huge amount of glucocorticoids made. That's why you can show that the cortisol in your blood is high when you're under stress. And stress leads as well to the breakdown into major depression or an anxiety disorder. And what is the consequence of putting stress on your DNA, on your genes? Well, many. Obviously, it can produce major depression or anxiety disorder, but let's look at this. The BDNF gene, you know what that is? Brain-derived neurotrophic factor. It's sort of a neurotrophic, you could say brain fertilizer, okay? Well, stress makes your brain turn it off. Well, that is not a good idea. So what do you think the consequences are of not having fertilizer in your brain? And the answer is, on the left-hand side, your nerves die. Sometimes we call it apoptosis. If you get BDNF on the right side, you proliferate your dendritic tree, which is a way of saying you form connections. You have a vital neuron on the right, and you need BDNF to grow. In fact, if you're listening to this and haven't fallen asleep yet, and you're learning something that you walk away from, you are almost certainly secreting BDNF to make new synapses for new learning. And those of you under stress who probably aren't listening very well, then you have BDNF and your brains are not doing so hot. But that also is a concomitant. And you know how? This is so big you can actually see it in the brain. If you take a slice in a scan right through your hippocampus, look at this. You see the red circle? That's a normal, fat, juicy, round, almond-shaped hippocampus. And actually the amygdala's around there. Look at the skinny, thin, rotted, decayed, atrophic PTSD or depression circuit you see. Not good. Now, that's bad news. And obviously, if you lose a brain, you got consequences to that. You're losing connections and you're losing memories in this part of the brain. But the other thing that's good news is that there is evidence that if you reverse the symptoms with medicines or psychotherapy, whatever, reduction of the stress. You can grow that back. So that's the good news. All right, let's talk about the description or phenotype of anxiety. And I told you that you could take anxiety and basically pull it apart. We'll call it deconstruct. Pull it into two things: fear and worry. Those are two big categories. And I told you each anxiety disorder has a little different flavor of fear and a little different flavor of worry, but they both have both. So why do you care? Because fear lives in the amygdala, whereas the worry lives in really a part of your cortex that goes into a circuit, sometimes called CSTC, cortico-striatal thalamic cortical. So that's where worry is. And that's different than fear. And so depending upon which circuit is sick tells you whether you have both or neither. And it turns out that almost all anxiety disorders and almost all patients with those anxiety disorders to a certain extent have a little of both. So here is your idea of a worry. C, which is basically the top thing, D, L, P, F, C. If you want to have a crazy rap song neuroanatomy lesson, you can go to my YouTube channel and listen to the DLPFC, dorsolateral prefrontal cortex. That's the part of the cortex that goes to the striatum, goes to the thalamus, and right on back, CSTC. And when it gets buzzing and going too fast, and the information processing gets inefficient, and that causes various types of worry. Now, there's worries that are obsessions. There's worries that are general. There's worries about panic attacks. There's all sorts of worries. And if you have a worry loop, it's right here. How about fear? Well, fear is a more base, guttural kind of automatic response. It's almost part of survival of the species. And animals have a lot of fear, and they use it. And so it's centered on the amygdala. And I'm going to talk a little bit about how the amygdala is wired into all sorts of important areas of the brain. OFC, orbital frontal cortex, ACC, anterior cingulate cortex. So fear is in a different part of the brain than worry. So guess what happens when you have fear? You not only have the affective component, which is what this guy is. He's going crazy. So, he doesn't have good feelings. But also, what else happens? PAG, periaqueductal gray. If you activate a wire, a circuit, that goes from the amygdala to the periaqueductal gray, you'll have a different type of fear response. You'll freeze. There's certain animals that when they're afraid, they freeze, and other ones flee. And so this is how you're wired to respond to fear in terms of evolutionarily. Some of us as humans, when we're in a bad situation, we freeze, and others have to get out of there. So this is really part of the PAG wiring. If you have another wire that goes to the hypothalamus, this is involved in some of those hormone effects that I just told you about, HPA axis. But if you have chronic cortisol going up, it's not good for your health. It can change you into having coronary artery disease, or if you've got it, make it worse. Same thing with type 2 diabetes, and it can increase the chances of stroke. So it's not good to be in chronic fear, obviously. It can also go to another part of the brain. So this is parabrachial nucleus. What happens there? Breathing. You ever see a patient that says, I can't catch my breath, or I feel like I'm smothering? That's not just, made up in their head. That is because an amygdala response to the parabrachial nucleus is essentially setting off a false alarm of suffocation. And this can give you shortness of breath. It can look just like an asthma attack, or it can look just like, a pulmonary attack. Have you ever seen that in the emergency room? I bet you have, because that's what people come in with. They're choking. How about autonomic? The locus coeruleus, LC, is the headquarters for noradrenaline, norepinephrine. And what does that do? It drives all the autonomic responses, cardiovascular things like your pulse, your blood pressure, and those sorts of things. So obviously, when you're fearful, your pulse goes up, and you're sweating, and you may have tremor, and pupils get big. And that's because the amygdala is saying, hey, locus coeruleus, give me a fear response. I need to do that. I need to flee. I need to activate the alarm. And finally, the hippocampus. Basically, we call it an internal fearmonger. It says, I went into that room before and I had fear. So, oh my God, I'm going to have fear again. So you begin to associate the memories of fear. through the hippocampus wiring into the amygdala. So really what's happening in a certain way is here's your almond-shaped orange amygdala, and you get input from all parts of the cortex, right and left. And then you get output, which is a fear response. And there's some nerves in the middle of that almond-shaped amygdala. And it doesn't stay the same once you have a fear response. It basically learns conditions. In other words, you can learn to be afraid and watch what happens. And this is the development of an anxiety disorder. So the first time you have fear, you start to say, okay, here's a synapse. See that? That's glutamate being released onto a glutamate neuron. It goes down here and goes to again, and then out comes fear. And that's how you have it. And the more orange clouds you have, the tighter the synapses are. Remember, there's an old saying, the nerves that fire together wire together. So the more you do this, the more you practice your fear, the more fear you have, and the easier it is to have fear. And this is part of the evolution of the sick circuit. That's called fear conditioning. Now, you can have fear extinction, but it's not easy. It doesn't happen quickly, and it doesn't happen completely. What is that? Is if you actually stop being around the things that bother you, what will happen is that you will stop having fear. But you don't have fear by changing the neurons that have been wired. So fear, which is lost, is not lost by forgetting. You don't forget your fear. What do? You have a new learning that blocks the old learning. Here it goes. I'm going to give psychotherapy. I'm going to give medications. Glutamate just got released. In this case, it's going to go to a GABA neuron, which is going to make purple, which is going to be inhibitory and stop it, and the fear response stops. So there's psychotherapy ways of doing that, and there's medication ways of doing that. And that has to be done over and over again because you need to reinforce that new pathway that sort of unlearns you, but not really. It basically blocks the bad pathological learning. And it's interesting because you can use glutamate drugs to maybe help the fear reversal or the new learning to block the old fear. And there are some drugs in development that D-cycloserine, glycine-like drugs, because what you want to do is cause a synapse, and the synapse is formed when you do this thing called long-term potentiation, LTP. So you want to make LTP, and that's part of the drugs, but it's actually a big part of psychotherapy. So I mentioned a little bit about the treatments. Let's get a little more specific. What are the treatments for the principal anxiety disorders? Well, obviously, there are psychotherapies, and I'm not really doing a psychotherapy talk, but I've written books on this. And in fact, the book I wrote on just anxiety disorders, we concluded that if you had psychotherapy or you had medications, that actually psychotherapies did better. Now, the two together did better than either alone. But why do psychotherapies do better for anxiety disorders? Because you learn. And after your psychotherapy, if it's effective, it keeps on being effective. On the other hand, if you take a drug and you block the fear, guess what happens if you stop the drug? The fear often will come back. So what's really another way to say it is that the learning you get in psychotherapy activates genes to make new synapses, a fancy term for epigenetic drug. Essentially, your psychotherapy is a drug. It's an epigenetic one. It activates synapse formation. So you form new synapses to learn to re-regulate, and specifically, of course, cognitive behavioral therapy, exposure therapy are the very well-proven psychotherapies for various types of anxiety disorders. Exposure therapy more in PTSD, CBT for perhaps all of them. Really, I'm a psychopharmacologist, even though I do psychotherapy. This lecture's on psychopharmacology. And so you've got the principal treatments are the famous SSRIs, SNRIs, serotonin selective reuptake inhibitors, serotonin norepinephrine reuptake inhibitor, benzodiazepines, alpha 2-delta ligands, noradrenergic agents. And I would talk about psychotherapies. So how do we actually use this information about the symptoms and their circuits to find treatments? Well, the answer is to recall that the fear is amygdala-centered and the worry is CSTC, probably from the dorsal lateral prefrontal cortex centered. So let's take the fear first. What regulates the amygdala? And the answer is look at all the neurotransmitters: serotonin, GABA, glutamate, CRF, norepinephrine, voltage-gated ion channels. So you have all these chances to modify the amygdala-centered circuit to reduce the inefficient information processing and make the symptom go away. So it shouldn't be surprising that those drugs will work. Well, there is some overlap with worry. The CSTC circuit is also similarly regulated by many of the same drugs, with a couple of exceptions. So if you know the symptom, you know the circuit, then you know the neurotransmitters that regulate the circuit. The next thing is you got to know the drugs and how they regulate the neurotransmitters and give the drugs to tune the circuit. It's sort of like, a violin or a guitar. You pick it up, it's out of tune. And so you tune it with your fingers, don't you? But it's just as much out of tune if you go too far as if you don't go far enough. So guess what the fingers on the tuner are? Those fingers are your drugs. And so you do that every day. You're tuning circuits with neurotransmitter targeting drugs that make symptoms go away by making the circuit more efficient. So let's go back again. What are the SSRIs or SNRIs? Well, there's a bunch of them, of course. There's some that are more sedating, paroxetine, fluvoxamine. Some people prefer a sedating drug. It's often very good at the beginning of treatment, but often not so good after the person gets somewhat better because they don't want to be sedated after they're feeling better. There's also activating ones, which can be a little touchy to use. You have to start the doses lower and go up more carefully because you can actually make anxiety in the short run a little bit worse. And then finally, you've got some neutral drugs there. And you can choose an embarrassment of riches. Whatever you want to do, you can choose from this list. How do they work? Well, remember our amygdala is going to all these places. I'm going to put them all together here in this slide. And guess what happens? Serotonin is going to come and take this activated circuit. You're anxious now. You have problems breathing. You have your hormones going places. Oh my gosh, all the things activated from fear. And now, look at this. See that yellow little neuron? It's a pretty important one. It's coming from the midbrain raphe and squirting serotonin centrally on that amygdala. And by so doing that, guess what happens? There goes the serotonin, and then down goes the high-wired, high-output nerves from the amygdala to reduce your fear. And that's why the cornerstone of treatment of most anxiety disorders is an SSRI. Now, how about that old CSTC circuit where you got worry? So basically what happens is that serotonin also goes to each of the major nodes, the striatum, the thalamus, and the cortex. And if you activate that with SSRIs, there's a yellow coming out in all the places, your worry goes away. And another thing that happens, remember that old BDNF story I told you? What's good about serotonin is the long-term effects, because if you change serotonin signaling, you'll turn back on BDNF. So here's serotonin going to G proteins, which then goes inside the cell to activate second and third messengers to then change things that are called transcription factors. And those transcription factors are essentially a switch that turns on the synthesis of BDNF. And guess what happens if you do that? You make more connections, your cells survive, and you prosper. So this is a longer-term effect of serotonin. It's not just to reduce the overactive circuits, it's to also cause plasticity. How about the famous benzodiazepines? These are somewhat controversial because sometimes they're overused. It's not a good idea to use them in someone who has any kind of other substance abuse. That's pretty not good. But they are very effective drugs if they're taken as directed, if the doses are not escalated, and sometimes as an augmentation to the SSRIs. The best studied examples are alprazolam, clonazepam, lorazepam, and diazepam. choose your targeting drug. I will say very quickly, though, that the data that these are effective in OCD are just kind of weak, and they can help a little bit, but not really robustly like SSRIs. And also, they're probably bad in PTSD. On the other hand, the other three anxiety disorders, GAD, panic, and social anxiety, they can be pretty good, but maybe they're not first line anymore. How they work, though, is by enhancing GABA. And guess what else? These same sick circuits, overstimulated, causing symptoms, will now have benzodiazepines enhanced by giving GABA acting agent, and then the fear will go down. It turns out that GABA interneurons are also present in the CSTC circuit. So if you give a benzodiazepine, you're going to enhance, particularly in the cortex, the GABA, which is inhibitory. It's a stop. It's a don't do that, and the worry goes away if the circuit stops being too hot. There's also two other agents for use. Sometimes they're used for pain. Sometimes they're used for epilepsy. But they're also effective. In certain countries they're approved, in other countries they're not, but they are effective for the symptoms of anxiety, gabapentin and pregabalin. They work by binding to a really cool protein that's part of a voltage-gated ion channel that's involved with the release of neurotransmitters. And the alpha-2 delta protein can be basically bound by one of these drugs. That's why they call them ligands. So what happens is that it's at the end of the nerves where they're releasing the neurotransmitter. So here, if you got your fear, your overactivated amygdala, and too much neurotransmitter coming out, and then if you actually, though, put an alpha-2 delta ligand at the end of these nerves, it'll prevent the release of glutamate. So even though the nerve is sort of active, it won't release the neurotransmitter, and your fear will go away. Same thing in the cortex. Alpha-2 delta ligands come in there, go to the end of the nerve, stop the release of the neurotransmitter, and then stop, in this case, the worry. So there are some other options very quickly. Noradrenergic. Alpha-1 blockers, people have heard that, particularly in PTSD, you can get nightmares, and prazosin can work for that. Beta blockers can also work to reduce anxiety, particularly when you have a lot of autonomic symptoms. And the N, which is noradrenergic, SNRI, serotonin noradrenergic reuptake inhibitors, can also work just like an SRI. So there's too much noradrenergic activity. Remember I told you that the autonomic nervous system is activated? And so there it is, too much lightning, out comes too much norepinephrine, and it's going to cause too much problems downstream. So what are you going to do about that? Well, one thing you can do is block it. You can block it with alpha drugs, and guess what? This is mostly, we think, related to nightmares, but maybe some of the other things. But you can also take beta blockers, because talking to the amygdala here is a noradrenergic neuron, and it's driving that amygdala crazy because it's too much. And if you take a beta blocker and stop the noradrenergic input to this fear circuit, it'll turn it down. So in summary, ladies and gentlemen, here we've got it. There are 5 principal anxiety disorders if you count all 5 the way I like to do it. There's at least GAD, generalized anxiety disorder, SAD, social anxiety disorder, and panic disorder, PD. And classically, you can include post-traumatic stress disorder, PTSD, and OCD, obsessive compulsive disorder. Many overlapping symptoms. All 5 of these have some form of fear and some form of anxiety. Each symptom and every anxiety disorder is hypothetically mediated by a specific malfunctioning brain circuit. And we just told you many of these are centered on 2 places of the brain, the amygdala or the cortex. Each circuit is regulated by specific neurotransmitters, especially serotonin, GABA, and noradrenaline, and that's why our drugs really work on those. So, I didn't talk a lot about it, but I will want to emphasize for balance, both psychotherapies and psychopharmacology can modify this inefficient information processing in the brain circuits that mediate the symptoms of anxiety disorders, and by doing that, relieve those symptoms. So thank you very much. I hope you enjoyed that. I enjoyed giving this for you. We'll take some questions, and I hope to see you sometime in Brazil.